Staphylococcus, Fusobacterium, Bacteroids. What are the clinical features of pneumonia? Like most of the diseases in kids, the signs and symptoms are not specific. As they say, kids don't read the textbook and come to the hospital, so there's no one pathognomonic feature for pneumonia. But when we see a child with cough and potentially a pneumonia, you have three kind of goals that you want to catch. You want to know whether it's a pneumonia or a kind of asthma. You want to know the etiological, possible etiologic agent, and you want to assess the severity of the illness. So have a look at this baby. These videos are taken from YouTube, and I'll be sharing the link in the description. But this is exactly how a child with pneumonia looks um, overall, or any kind of lower respiratory condition. You can see that this baby had marked recessions. They don't look very comfortable. They have an audible kind of wheeze. Have a look at this baby as well. You can see that the baby is having head bobbing. The baby is having an audible wheeze. She's totally not comfortable, and she's on oxygen as well. Have a look at this last baby.
Here we go. Okay. It's okay. Okay, take a breath, honey. Come on. Almost there. Here we go.
So sorry for the last video. I accidentally moved the slide forward, but you could see that the child is having bouts of coughing to the point that she is not able to breathe well, and you can hear the by the end of the video the monitor starts to beep, which probably means that her oxygen level has gone down. So, and followed by this coughing spell, she has a whooping sound. So when you're taking history of a cough, it's very important that you ask about these things, because parents don't usually know that this means there's a very high chance that this child had pertussis, and the video had actually mentioned that she does have pertussis. So that was just a quick look and of what you will see the different phases of pneumonia. And of course, these kids all had a severe pneumonia. There's definitely cases of mild pneumonia which don't need any oxygen, don't need any hospital intervention, which is what we will discuss in the coming slides. This is a quick table from up to date. You can just have a quick zoom in, but it basically follows the basic history components which you need to follow for any kind of pediatric illness, starting with history of presenting complaints and going on to systemic review and the rest of the history. But a few important points here, from the associated symptoms, if you have, for example, a lot of extrapulmonary manifestations, let's say the child has a headache, he has a sore throat, he has a cough, he's a 4 or 5 year old child, this will raise some alarm bells for mycoplasma pneumonia, because mycoplasma is a kind of jack of all trades, or mycoplasma knows how to affect a lot of different systems in the body. So if you have a child who's coming with this kind of picture, especially if he's coming in the school age range, you would be suspecting mycoplasma pneumonia. We know what the features of severe pneumonia are. If you have a child who's looking the way the previous kids did, you you don't even need to per se ask the parents. The picture is in front of you. But let's say the parents say he has very fast breathing, the fever is quite high, he's not eating well, he's not able to breathe comfortably. You know that this is going with a severe pneumonia. Any kid who's not eating and drinking well means that they have a severe kind of infection. They are not well. They need your attention. If you have a history of a choking episode, this will raise your alarm bells for an aspiration pneumonia. And if you have a duration of symptoms which is going very long, like more than 4 weeks, you'll think about the other dangerous etiologies. Like we mentioned previously, it could even be TB in the child. So I'll leave the rest of the reading to you. This table was taken from up to date. Coming to the physical examination, I won't be going over that slide, but we've discussed it in the videos part. So the most important examination features. What I will go over though is this table, because it's kind of repeating the same thing. But what should you be aware of? What are the signs of severe pneumonia? If you have a very high fever, respiratory distress, cyanosis, altered mental status, low oxygen, not feeding, fast heartbeat, and dehydration, these are all features of severe pneumonia, which are the red flags. If you are taking care of any child, you should you should be able to catch these and recognize that the child is really not well. So let's have a kind of exercise here. This is again slightly more theoretical. In real life, you can have a big mix of etiologies. You can't say 110% that no, because the child has X, Y, and Z, it's a viral infection as compared to a bacterial infection. But it's a general kind of principle. So if you have a child with abrupt onset of illness, he's ill looking, he has shivering, he has respiratory distress, high white cell count, and focal auscultatory findings, like one part of the chest has an infection, this is going more with a bacterial infection. If you have a child with gradual onset of symptoms, he has some upper airway symptoms like a runny nose, cough, some mild ear pain, he's looking overall fine, not as sick as the big kids in the video. You have some diffuse bilateral auscultatory findings. So there's not one place where you can hear reduced air entry. There's not one place where you can hear crackles. There's some wheezing. There's some skin rash. This is going more with a viral infection. If you have a child with a chronic cough, which means more than 4 weeks, with constitutional symptoms. So constitutional symptoms means like weight loss, reduced appetite. He's not looking. He has a history of not looking well for a long time, and of course exposure history. You will think about tuberculosis. If you have a child with of any age, more commonly more than 5 years, with a lot of symptoms like body ache, headache, rash, eye redness, sore throat, headache, worsening non-productive cough, wheezing, and a huge range of weird symptoms which you would never expect are coming because of one organism, like hemolytic anemia, hepatitis. This goes with an atypical bacteria also known as Mycoplasma pneumonia or chlamydia, but usually all of these are going with mycoplasma. If you have a child with rhinorrhea, staccato pattern, cough pattern, which to be honest I've never seen in real life, but it's a special kind of cough, and you have some eosinophilia. This is afebrile pneumonia of infancy or atypical pneumonia, and this is how it looks like in neonates. What are the investigations? Usually, you will diagnose pneumonia clinically, and this means that through history and physical examination, you can ascertain that there is a lower respiratory tract infection. And generally speaking, if the child is very well and you're not planning to admit the child to the hospital, he's looking fine, you can discharge them on antibiotics without having performed extensive investigations or an x-ray. But of course, if you're suspecting a sick child or someone with clinical features of severe infection, you have to go for an x-ray and perform some labs to get a better picture of what's going on. More advanced labs, like let's say uh, viral panels or mycoplasma testing, CT scans, these are usually not done at the very start, or if you're really suspecting something specific that requires that level of imaging. But for the on a general level, you'll usually start off with history examination and a limited set of investigations which will support or contradict your final diagnosis which you want to make. It's not wise to jump with more investigations, more advanced imaging, because that will ultimately confuse you and it will not help you, it won't help the child. So, this is a bit of a clinical point. Um, so, if you want to do a rapid diagnostic test, let's say the viral panel, which I was mentioning, they can help in making cohorting decisions. So it's a bit of a clinical point, but what's the point, you may ask, of doing a viral panel? You have a test of, let's say, depends per hospital. If you find out if the child has RSV, if the child has adenovirus, so what? You won't be treating, there's no treatment for RSV or adenovirus or let's say COVID. But if you're going to admit the child, you could do a viral panel, and this will help you cohort the kids. So let's say you have a hospital, you want to put the RSV kids together rather than mixing the RSV admission with another baby who's admitted for something else. And rapid viral testing cannot be used in isolation to exclude a bacterial infection, especially because you can have a bacterial and viral infection. So that's kind of obvious. If you have, let's say, our patient who was 27 months old with this huge pneumonia, let's say you got RSV positive in that child. Would you say that this whole infection is because of RSV? Of course not. You can say that there's a co-infection, and you will not stop antibiotics just because the RSV has come positive, but you'll take it in stride and say, fine, the child has an RSV, but clinically, of course, it's a bacterial infection and you need to treat accordingly. You never treat numbers or lab reports, you treat the child as a whole. So you have to use your investigations wisely. And yes, you will not differentiate colonization from infection just by doing a rapid panel. You don't know. Maybe the sample was not taken properly. Maybe the child has a colonization with this certain bacteria or virus. So you can't even tell if it's acute or if it's present as a colonization. And this is especially true for those who are having an abnormal like lungs, let's say like a cystic fibrosis patient. When do you do a chest x-ray? This is a very common question which a lot of physicians will ask. So you will go for a chest X-ray if you're suspecting a severe disease, when you want to confirm or exclude a kind of diagnosis. Let's say you're suspecting an aspiration pneumonia. You want to do a chest X-ray to find out what's going on. Or as in our case, you have very reduced air entry and you're having a severe kind of distress. You want to check if there's how bad the pneumonia is, if there's a pleural effusion or not. If the child is that sick that you need to hospitalize him, of course you need to do a chest X-ray because you need a baseline and you need to see exactly what's going on. If you have a history of recurrent pneumonia, and recurrent pneumonia is important because sometimes the child has an abnormal airway and lung anatomy. So one part of the lung continuously repeatedly gets infected. So you can suspect that there can be an airway anomaly, or you want to exclude an alternative explanation for respiratory distress, like you're thinking of a foreign body. So, or you're thinking of heart failure if the child is just having respiratory distress, no fever is there. So in that case, you can perform an X-ray. Or if you're suspecting a complication, let's say the child has a pneumonia, you started treating it, like in our patient, and she never got better. So you need to do an X-ray to find out what's going on. And the last point is if you have a very young child, like 3 months to 36 months, who's having high fever, high white cell count, you want to do an X-ray to rule out pneumonia. Because sometimes if the baby is that young, they don't really show you that they even have a pneumonia. So you need to do the X-ray to catch it. Usually, for a child who's older than 4 years, you will do a PA, upright chest view, because AP means that the child is facing the X-ray machine, and usually their heart shadow will be big and it will not allow you to see the lungs very well. So you'll do a PA, so posterior anterior. But if you have a younger than 4 years child, it doesn't really affect, and you usually just go for the simple AP view. And the lateral view of the X-ray also can be supportive. It can help you visualize the dome of the diaphragm as well, and to see if there's any infiltrates behind that. And an exam question and clinical point as well is that if you're suspecting a pleural effusion, you should do the lateral decubitus chest X-ray. These are all different kinds of pneumonias which are for your interest. And you can see that there's no one way that pneumonia looks. You have the X-ray, you need to have the previous physical examination, clinical points to help you determine that yes, this is something significant on the X-ray, and you need to proceed for treatment. What are the complications of pneumonia? Exactly like we have discussed, our patient had a pleural effusion, she had empyema. There can be necrotizing pneumonia, like we mentioned, can happen in Staph aureus, and the most common cause is strep pneumonia with of serotype 3 or 19. Sorry, serotype 3, serogroup 19. There can be a lung abscess, pneumatocele, and hyponatremia, which is a really interesting finding that pneumonia patients, and it's good to remember, patients with pneumonia can have low sodium levels. Here you can see a picture of a pneumatocele, which is like a kind of cyst or a circle, which is usually present with Staph aureus. And here you can see a kind of lung abscess. So there is an air fluid level. The air is black and the fluid is white. And this is a lung abscess. What is the treatment? If the child is not very sick, you will do general supportive measures. You will give antibiotics if you're suspecting a bacterial infection, and you'll go for the supportive treatments. And chest physiotherapy, like we gave for our patient, you're not going to start off the chest physiotherapy in the acute pneumonia phase. Once the child is afebrile, she's recovering, they're shifted to oral antibiotics, and you have that kind of pneumonia which needs drainage of the sputum, like a big pneumonia in our patient, you'll consider chest physiotherapy at that time. What are the indications for hospitalization? To cut it short, um, The indications are severe pneumonia. So you'll find that this list of indications is all matching or parallel to the cases of severe pneumonia. And that includes a child, as you can see in point number 5, with an underlying condition that may predispose to a more severe course of pneumonia. In the easiest example I can give you is a child with cancer. Let's say you have a child with cancer and a pneumonia. You're never going to send them home unless they are very, very mild or in a very, controlled circumstance. But you'll treat them in a special way and you need to keep them under observation. ICU. When does a child need ICU admission for pneumonia? The core point or the core answer for this is when the child is going into respiratory failure, or they are losing their ability basically to fight the pneumonia. If you can imagine a child, let's say in the middle video, okay, she's coughing continuously, or the other kids who are breathing very fast continuously. It's as if you're running a marathon for the child. You're exercising, you're using your energy. Every breath needs effort. So if you're in that kind of state for so long, then you expect that the child will develop fatigue. And once the child develops fatigue, they are on the slippery slope towards failure, or they are going, or they have reached into failure by that point. So instead of breathing fast, they start breathing slow. So instead of being alert and agitated, they become sleepy, tired. Um, the oxygen level will start to drop. The child will have lower blood pressure. They will have metabolic acidosis. And you have, as in this list, breathing fast, breathing slow, both of these are, if you have a child who's breathing very fast, it means that he will soon become tired, right? So have a good look at this list of indications, and you will see that uh, they are the end stage of a child who's been working very hard to keep breathing. We'll leave it here now. This is from Up to Date, and it's important, not particularly for medical students, but once you start clinical practice, these points will become a little bit important, like which antibiotic are you supposed to use. I'll leave it for you all here, and these are taken from Up to Date. So in your own time, you can have a look at these. But as I mentioned, that the core concept here when it comes to pneumonia is recognizing who the sick child is and who you need to investigate further, and then subsequently start off with antibiotic therapy. To finish off now, what are the mimics of pneumonia? You have a lot of things which can cause tachypnea or fast breathing, like heart failure, bronchiolitis, which is not usually easy in clinical practice to distinguish from pneumonia. But again, it's not a huge mistake if you diagnose somebody with bronchiolitis as compared to pneumonia, because they're both lower respiratory tract infections. As long as you have identified who the sick child is, decided whether he needs antibiotics or not, you are within the safe umbrella. Sepsis and metabolic acidosis, you need to have a good history and physical examination, and a holistic view of the patient to be able to catch all of these different kind of mimics for pneumonia. These are my references, and thank you so much for watching. Please do subscribe, and I hope that this video has been helpful.